frozen shoulder is a useful label, but it should not be where your clinical reasoning stops. One of the problems with terms like adhesive capsulitis is that they can imply more certainty than we actually have. They can make it sound like we know exactly what tissue is involved and exactly why the shoulder is stiff. But in clinic, stiff and painful shoulders are often messier than that. The patient might have painful restriction and a clear loss of external rotation. They may have restriction across multiple planes and symptoms that are stable or worsening over time. That gives you a useful clinical pattern. But the next question should not only be, is this frozen shoulder? The better question is, what else might be influencing this presentation? Because that same presentation can sit alongside diabetes, thyroid disease, or recent trauma, previous breast surgery, post-op shoulder stiffness, or neck-related symptoms, or broader health factors like sleep, stress, activity levels, and general health. Now, that does not mean every associated factor is causal, and that is the important part. It uses the label to create clarity, then keeps the assessment broad enough to avoid missing what matters. So instead of treating frozen shoulder as the whole explanation, use it as a starting point. Ask, does this presentation fit the clinical pattern? Is there a known or hypothesized linked pathology? Are there systemic or historical factors that change prognosis? And is there anything here that changes education, management, or rehab planning? That is the practical shift. The label should organise your thinking. It should not replace it. Clear label, broad reasoning, honest uncertainty. That is usually far more useful than sounding more certain than the clinical picture allows. Save this if you assess stiff and painful shoulders, and follow for more practical shoulder reasoning.